lab, I'll be starting off the pharmacoeconomic proposal presentation for Group 3. And the title of our project is Cost Effectiveness Analysis of Romosozumab compared to Alendronate in the treatment of postmenopausal osteoporosis. The objective of this study is to compare the cost effectiveness of Romosozumab versus the standard therapy Alendronate in the treatment of postmenopausal osteoporosis. We chose to test the cost effectiveness of Romosozumab and Alendronate for several different reasons. First, due to the rising use of monoclonal antibodies, not only in osteoporosis, but for many different indications. Also due to the high cost of monoclonal antibodies, since most of these drugs are injectables and they are newer drugs, so they are generally brand name, they are usually pretty pricey. In addition, with standard therapy of the bisphosphonates, such as Alendronate, there are several severe adverse effects, which kind of puts into question if there are better drugs out there for the treatment of osteoporosis. And upon literature review, we were not able to find any analyses of cost effectiveness of Romosozumab. We found different ones examining other therapies for osteoporosis against Alendronate and other bisphosphonates, but since Romosozumab is a newer drug, we were unable to find a cost effectiveness analysis, which really indicated the need for one. Further influencing our choice to research postmenopausal osteoporosis treatments is its prevalence. By 2050, it's estimated that 6 million people will suffer from postmenopausal osteoporosis. Currently, 33% of women ages 50 to 60 have postmenopausal osteoporosis, and that increases to 50% in ages 80. A little bit of background about the disease. Osteoporosis in general is decreased bone density and increased degradation of bone. Bone is constantly remodeled throughout the lifetime, and menopause impairs this process due to estrogen deficiency, which leads to increased bone breakdown by osteoclasts and decreased bone formation by osteoblasts. To give a little bit more background on the alternatives of this study, Romosozumab is a monoclonal antibody that inhibits sclerostin, which then this inhibits osteoclast formation and stops the degradation of bone. It was FDA approved in 2019 under the brand name Avinity. Just for reference, the average wholesale price is around $2,200 per month. And Romosozumab is administered via 2 subcutaneous injections delivered at the same time by a healthcare professional each month. They come in pre-filled syringes containing 105 micrograms per 1.17 mils. Alendronate is a bisphosphonate. These drugs work by inhibiting osteoclast activity on the bone, therefore stopping the breakdown of bone by the osteoclasts. The average wholesale price, for your reference, is about $81 per month. It's administered via a weekly oral tablet that contains 70 milligrams of the drug. It's standard therapy for postmenopausal osteoporosis and several other types of osteoporosis. It's been out for a while. It was FDA approved in 1999. The overall design of this study is a cost effectiveness analysis. So our costs will be measured in dollar units, and our outcomes will be measured in clinical units. Both the costs and the outcomes will be discussed in greater detail in the following slides. For the study, the data will be collected from patients that received a new prescription for either drug, Romosozumab or Alendronate, between May 2019 and April 2020 within the SSM health system. We chose these dates for patients to enter the study since Romosozumab was FDA approved in April 2019. We obviously could not have any data collection before the drug was FDA approved because doctors would not have been prescribing it. We also wanted there to be enough prescriptions to be collected, enough patients within the study. So we extended it to April 2020 to get more patients in the pool. And then costs and outcomes will then be collected from the patient for a year after the initial prescription was prescribed, or until the drug is discontinued or death.
The outcomes for our trial were selected based on current outcomes for safety and efficacy regarding current osteoporosis treatment. One such outcome is a patient's T-score, gathered from a DEXA scan. This score will help us track the bone density of our patients, a good indicator of their osteoporosis progression. Other outcomes include osteoporosis fractures, such as hip, femur, and spinal fractures due to weakened and decreased bone mineral density. Other secondary outcomes and effectors of cost include adverse events from the therapy chosen that often require medical attention. For bisphosphonates, this includes atypical femoral fractures, osteonecrosis of the jaw, esophageal ulceration, GI bleeding, bone, joint, and muscle complaints, and hypocalcemia. For Romosozumab, this includes bone, joint, and muscle complaints as well, cardiovascular events, and injection site reactions. For our study, we chose to look at the cost from the healthcare system perspective. Since our data pool consists of all hospitals in the SSM Health Systems network, medication cost will be defined as the acquisition cost for SSM systems from their supplier. Their cost of storing the medication and having it on hand for treatment will come from hospital records and budgets. The office visit costs include that of follow-up visits, as well as those for the monthly administration of Romosozumab by a healthcare provider. For treatment of fractures, this can include scans and imaging to diagnose said fractures, casts and or possible surgery, as well as subsequent visits to follow up on the fractures. Cost of treating serious adverse reactions that require medical attention will also be included, and this includes the costs of the visit and subsequent treatment for these adverse reactions. All of the costs will be adjusted to the 2021 value. As our data collection ends in 2020, an analysis will be conducted in 2021. Next, we have data collection. As stated before, the perspective of our study is from that of the healthcare system perspective, and we will be using the SSM Health System to conduct this study. This system was chosen because it provides for consistency among data collection and documentation, as all SSM hospitals will be running on the same system. This will provide consistency among medical records while ensuring a large population to select study participants from. This also allows for consistency among hospitals for their costs, as they are all in the same SSM network. After the initial data collection is complete, a sensitivity analysis will be performed on the baseline characteristics of the study subjects. We plan to perform a sensitivity analysis on our subjects in order to reduce the risk of bias added to the study due to confounding variables in the baseline characteristics of our patients. Like any study, our study contains certain limitations and assumptions. To begin, our study focuses on postmenopausal osteoporosis. This limits, if not eliminates, any generalizability of our study results to that of other types of osteoporosis, as well as limits our data collection pool. Not only this, but this also means our study is not generalizable to the treatment of osteoporosis in male patients. Our study will be conducted strictly within the SSM Health System here in the United States of America. This limits our study pool to that of patients within the United States. And while there is a possibility some of those patients will not be U.S. residents, it is highly unlikely. Our study is also limited by the fact that data collection is only from the SSM Health Systems network hospitals, and there are patients of postmenopausal osteoporosis that will be seen at other hospitals and other networks. This also creates another limitation, that patients may receive care such as ER visits to hospitals outside of the SSM Health Systems network. Finally, our study assumes that patients who receive a prescription will be taking the prescription appropriately, remaining adherent to the medication. Our study proposal also assumes that doctors will be prescribing Romosozumab at significantly higher rates high enough to allow for adequate amounts of data collection to create a significant comparison between Romosozumab and Alendronate. The generalizability of our study is dictated by the limitations discussed previously. Our study focuses on the treatment of postmenopausal osteoporosis, limiting our generalizability and eliminating any to that of other types of osteoporosis. This also limits our generalizability to strictly female patients, especially that of an older population. Our study is also limited to generalizability within the United States. This is due to our data collection pool being strictly within U.S. hospital systems of the SSM network, and the cost difference between prescription medications in the United States and other countries. The structure of health systems and standards of care in other countries can also vary from that of the United States, thus reducing any potential for generalizability to countries outside of the United States. This concludes our presentation on the cost-effectiveness of Romosozumab compared to standard therapy of Alendronate in the treatment of postmenopausal osteoporosis. Please feel free to email myself, Morgan Dermody, or Lauren Staub if you have any questions. Thank you.